Bismillahirrahmanirrahim. I am very thankful to all of you for participation in this seminar here in Dubai, and here is my lecture which I presented in Switzerland, and this was the topic on which I got my PhD from Switzerland. This is sonographic evaluation of patients with acquired immunodeficiency syndrome, which is called AIDS, and I am Dr. Gilani, Director of Middle East Branch of Jefferson Ultrasound Research Education Institute from Department of Radiology, Thomas Jefferson University Hospital, Philadelphia, Pennsylvania, USA. There are different areas which are affected by AIDS. These include central nervous system, respiratory system, abdominal retroperitoneal system, and superficials. The central nervous system, there are limitations for ultrasound imaging imposed by bony, calvarium, and vertebrae. Limitations on ultrasound imaging in the respiratory system are imposed by air in lungs. So we can see the abdominal, retroperitoneal, and superficial structures by using ultrasonography in the AIDS patients. Sonographic findings: prevalent non-specific abdominal abnormalities associated with AIDS include Splenomegaly, Hepatomegaly, hyperactive liver parenchyma, gallbladder wall thickening, lymphadenopathy, nephropathy, and maybe incidental finding unrelated to the process responsible for the acute symptoms. Here we have a case which was a known case of AIDS. In this patient you can see lymphadenopathy, and here are the lymph nodes, large lymph nodes showing dilated CBD and extensive lymphadenopathy. On biopsy it was confirmed as a case of lymphoma. Another patient which was AIDS patient having questionable lymphadenopathy. We scanned this patient with 3 MHz probe, and it appeared as a large node which was 3.4 centimeter, and we considered biopsy. But by using 5 MHz probe, it appears that these are actually small multiple nodes, and although there was some indication for the biopsy, we can confirm a smaller lymph nodes, but the diagnosis was more clear that this is not 3.4 centimeter large lymph node. These are small matted lymph nodes. 2 different AIDS patients with necrotic lymph nodes. These are the necrotic areas and anechoic areas within that. This patient had Mycobacterium intracellular infection, and this patient had Mycobacterium tuberculosis infection. Both of them having lymphadenopathy with necrotic changes. Bowel disease associated with AIDS include AIDS enteropathy, and infections which are common are gastritis and colitis. In AIDS enteropathy, the most common indications for emergency laparotomy in AIDS patient with abdominal pain involve pathology of the bowel. The infections which are common are gastritis and enteritis, frequent non-surgical causes of abdominal pain. Cytomegalovirus infection causes vasculitis in submucosal blood vessels, leading to ischemia of the affected bowel segments, and is the most common cause of bowel perforation and toxic megacolon. AIDS patient with abdominal pain. Patient came with abdominal pain, and on ultrasound we found that there are nodular thickening of the jejunal fold. This is the lumen, and the wall is thickened, which appeared nodular. It is due to MAI enteritis. So the gastritis and enteritis are usually caused by infection with Candida, cytomegalovirus, mycobacteria, or cryptosporidium. There is a case of AIDS enteropathy with cytomegalovirus colitis. You can see the lumen which is hyperaquic and thick walls, inflamed thickened walls. There is marked thickening of ascending colon wall indicated by the arrows, and this is the hyperaquic lumen. If the colon is abnormal, the diagnosis is likely pseudomembranous colitis or infection with cytomegalovirus or Mycobacterium tuberculosis. Disease of the peritoneum associated with AIDS, ascites was found in 14% of sonograms performed in AIDS patient in large series. Thickening of the peritoneal lining was there. In a study which was done in 1994 by Smith F. Seattle. Here we have another case of AIDS patient with abdominal pain and distension, and you can see there is ascites and thickened liver capsule. Paracentesis showed that this was infection with Candida. Patient with abdominal abscess, a nice sonogram. You can see the pyogenic bacterial abscess in left lower quadrant. This is fluid level formed by debris, and this is fluid. Then is hepatic pathology associated with AIDS. Cardiac dysfunction is common in patients with AIDS, particularly IV drug abusers with a history of endocarditis. Abdominal sonographic findings indicative of cardiogenic congestion include Splenomegaly and dilatation of the hepatic vein and IVC. Here is a patient of congestive heart failure. You can see the vessels which are dilated, transverse view of IVC and longitudinal view of IVC. This is portal vein and hepatic veins with caudate lobe, ligamentum venosum, and this is dilated longitudinal view of IVC. And we confirm that on transverse view with hepatic veins which were engorged due to congestive heart failure. Hepatic pathology associated with AIDS include non-Hodgkin's lymphoma, 25% have focal lesions, hepatocellular carcinomas, Kaposi's sarcoma. In Kaposi's sarcoma, small hyperaquic nodules and periportal thickening is seen, and we can find opportunistic infections as the immunity is decreased in AIDS patient. Many opportunistics are coming like pneumocystis carinii, MAI, cytomegalovirus, and microabscesses. There is a lymphoma in the liver. Variable echogenicity is hyper, and aqueous target lesions can be seen. Variable distribution, usually diffuse. Here is a case having diffuse distribution of the lymphomas. AIDS patient with hepatitis C, and there was a target lesion in the liver, and on biopsy it was confirmed that it is a lymphoma. Another AIDS patient with hepatitis B and having a large hepatocellular carcinoma, and we confirmed that on biopsy. Another liver with microabscesses, usually less than 1 centimeter. Target or bull-eyed lesions were there, and most common are the fungal infections like Candida and Aspergillus. Then comes biliary pathologies associated with AIDS. It includes AIDS cholangiopathy, AIDS-related sclerosing cholangitis, a disease that is unique in AIDS patients, believed to be primarily caused by biliary infections with cytomegalovirus or cryptosporidium. Sonographic findings include mural thickening, irregularity, dilatation, and strictures of the ducts. There is AIDS-related sclerosing cholangitis. You can see the dilated intrahepatic ducts. Here is dilated CBD with irregular mucosa. You can well appreciate the irregularity of the mucosa and a stricture there with CBD. Here is AIDS cholangiopathy. We can see the thickening of CBD wall, which was confirmed on transverse scanning. AIDS-related sclerosing cholangitis, another case which was confirmed on cholangiogram. Here is the thickening of common hepatic duct. Diffuse gallbladder thickening, it has different causes like cholangitis, pancreatitis, chronic congestive heart failure, tumor infiltration, adenomyosis, sepsis, and AIDS cholangiopathy. There is a patient of AIDS having AIDS cholangiopathy, and there is thickening of the wall. There is another case of AIDS cholangiopathy, and you can see on longitudinal and transverse view there is edematous wall. We know that the normal size is up to 3 to 3.5 mm in most of the literatures, but in this patient it was 17 mm. Then we come to the pancreas. The pancreatic pathologies associated with AIDS include acute pancreatitis, common in AIDS patients, caused by various opportunistic infections and medications. Develops in 25% of patients taking adenosine. May also be caused by ARSC, particularly in patients with papillary stenosis to whom the pancreatic duct may be obstructed in 81% of cases. Here we have patients of acute pancreatitis. You can see the size of the pancreatic body, the size of head of pancreas are increased. It is hypoaquic as compared to the normal texture, and there is dilatation of the pancreatic duct, which was confirmed on cross-sectional view at the level of body of pancreas. Then we come to the splenic pathologies associated with AIDS. We can find splenic abscesses, we can have splenomegaly resulting from lymphoma, and small splenic lesions due to opportunistic infection and lymphomas. Here is splenomegaly. You can see the liver touching the spleen, which is called kissing sign. An AIDS patient with splenomegaly resulting from rapidly growing lymphoma may present with severe abdominal pain. This is stomach, which is empty, and there is the kissing sign. In spleen, small splenic lesions are often seen in AIDS patients with opportunistic infections and lymphomas. Here is a scan of spleen with 3 MHz splenomegaly, but no lesion was seen. But when we scanned with 7.5 MHz frequency probe, intrasplenic lesions, which were the fungal abscesses, was visualized. So be careful while scanning AIDS patients. AIDS patients with extrapulmonary pneumocystis carinii, we can see the granulomas, which are the splenic granulomas. Then we come to urinary tract pathologies associated with AIDS. The first is HIV-related nephropathy. Generalized increase in parenchymal echogenicity. So the parenchyma is hyperaquic. A shining kidney will be there. Then there will be pyelonephritis detected sonographically as thickening of the pelvocalyceal system. Thickening can also be observed in HIV-related nephropathy, so this finding should not be misinterpreted as evidence of pyelonephritis or other acute pathologies of the upper urinary tract. Urinary stone disease, an increasingly prevalent cause of abdominal pain and associated with Enteropathy therapy. Here is HIV-related nephropathy. Patient with AIDS having hyperaquic shining kidneys. You can see in longitudinal and in patient having retroperitoneal pathology, which was the pre-vertebral collection. On ultrasound you can see abdominal aorta, and this is the vertebrae, and you can see a collection which was confirmed on MRI. This was on aspiration, it was confirmed that it is due to tuberculous osteomyelitis. Then we come to superficial pathologies associated with AIDS. These include lymphadenopathy, skin and subcutaneous lesions like Kaposi's sarcoma, glandular diseases like salivary gland involvement, parotids, and thyroid gland involvements. Here is a parotid gland in AIDS increasingly the modality of choice.